Are we ready? Good evening, Dr. David.
Hey.
How are you?
We're very well, thank you. And yourself?
I'm great. I'm really good. Thank you so much for giving me your time this evening to discuss such an important topic in my industry and in your industry.
Totally. No, it's all for a good cause, so my pleasure.
Thank you, thank you. So I guess there's a lot of people joining. So far we have about 20.
Okay.
I
Hi,
think
all.
let's just get started. There's so
100%.
much to cover.
Go for
So
it.
how about we start off with who you are, what do you do, and where can we find you?
Oh, okay. Well, I'm David. I am an ear, nose, and throat doctor, which means I pick noses for a living, and I am based in Queensland, but also work out of Sydney as well.
Yeah.
So I try and cover, my bases there. How can you find me? Well, you found me here. So I guess if people can find you here, they can find me here too, right?
Absolutely, absolutely. So what's an ear, nose and throat specialist? Because when I refer clients, they're just like, what's that? My GP says there's nothing wrong with my child's hearing, but they don't understand your role and the importance that you have on pediatrics.
Yeah. So look, ENT is a huge specialty. It's a bit like, talking about orthopedic surgery. Oops, Daisy. Saying, some do knees, some do hips, some do spine, some do, hands, whatever. So ENT is similar. And what that means, being such the big specialty that it is that we cover our bases, but then we branch off into little corners of the room. So pediatrics is one, adults is the big picture for the other. But, you could be an ear specialist, you could be a nose and sinus specialist, you could do facial plastics and cosmetic surgery. You can do throat cancer surgery. It's such a big range of things. And because of that, especially if you go and focus in one corner of the room, which is what I've done, then a byproduct of that means that there's certain parts of ENT that sort of I fall behind on. But I know that we sort of filter things so that we don't waste people's time and money. You can sort of say, look, what are you seeing for? Oh, look, he doesn't really do that. You're better off seeing someone that focuses on that. Because, like everything, you'll get a better result if you're dealing with someone that focuses on a particular thing more so than, anything else.
Exactly.
So in terms of how ENTs play into the role of kids, look, it's probably the number one reason collectively why kids are landing on the doorstep of GPs. Ear infections, throat infections, behavior problems. It's just a matter sometimes of appreciating how the dots need to connect to each other, so that you can understand that in one light you think there's not a problem, but then in a different light, it's if the sorts of things that we have to know, you go, actually, no, that is a problem. And it's the same. Like my uncle collects stamps, just to give you an analogy. So he specialises in a really, really, really specialised area of Australian stamps.
Yeah.
And he can go to a market stall and pick the stamps that they're selling for 20 cents that he knows are worth $200. Because he just knows. Right? But everyone else walking past just goes, it's just a stamp, it's just an old stamp. Okay, so it's the same. You can have people that know different things and so forth. And I think as I said, with ENT being a big specialty, I can't keep up with it all. And I think the role of the family doctor is enormous in terms of everything we want and desire and expect of them. But at the end of the day, they can't keep tabs on it all either. Just an ENT, let alone everything else. And things change and so forth. So part of what we have is you get sort of stuck with what you were taught, and unless you're in a position where when something has changed, you can get the update and the understanding and the knowledge, then you don't necessarily realize that things have changed around you. And that's part of the challenge as well. And that's why I do these things. Is there's no point in me knowing this and not sharing it. I'd rather go, all right, well, this is what lives inside my brain. This is what I know. This is what I think parents need to know about their child. And if the parents can have some better knowledge and understanding, because it's not like the child comes with an instruction book. It's not like your car where the red light goes on and says, take me to the mechanic because I've diagnosed that there's a problem that you need to get sorted. And a lot of things about kids just get fobbed off. Oh, that's normal for kids. It's just one of those things. They'll outgrow it. But those sorts of things really aren't recognising the concerns that the parents have. And yeah, look, I think hopefully through tonight, wherever we meander topic and conversation wise, and me being me, I'll just warn you that we're going to go off on tangents left, right, and centre, because it helps
I'll try
loop
to
back
navigate
and
it back
really,
onto the
yeah. Well,
speech and
basically, it's
communication
kind of like
field.
we're going to climb the tree. We're going to get from top to bottom, but there's different limbs of the tree that we're going to branch out on. But then we'll come back to the middle and we'll keep climbing. And it's all for a reason. It's just so that you get a deeper knowledge and understanding of things is what I hope people get out of this.
Yeah. So for those that are watching, I guess as a speech pathologist, when we meet a client, one of the most important questions that we ask is, has the child hearing been assessed? And most of the time, the parents reply, yeah, at birth, and they were screened. And secondly, they say, well, there's nothing really wrong with their hearing because they can hear the TV on. And so there's that misconception of, well, there's certain frequencies and decibels that your child needs to hear in order to process certain sounds and to discriminate different sounds in order for them to produce sounds, but also to learn how to communicate. So that's one of the biggest hurdles I sometimes have to encounter, just to get them to get their hearing formally assessed. But then they realize, oh, my child has fluid in their ear. And then that's that, let's wait and see what happens now. Let's reassess their hearing in 6 to 8 months' time. And to me, that's time wasted when we know the importance of early intervention. What are your thoughts on that? Let's wait and see, especially for child's
let me cover
2.5 years.
everything next. I think what you've unpacked there alone is really valuable. So let's go back to what we call newborn screening. Okay, so newborn screening is a test where we're trying to work out if a child can pick up a certain volume of sound. Okay, and it's actually not a hearing test. What it actually is a reflex. It's a bit like when you tap your knee and your leg kicks out. All right, what we're actually testing for is a reflex. And what we do is put a significant volume of noise into the ear, and the machine is very sophisticated because what it's measuring is if that sound has gone into the inner part of the ear, it generates a little electrical stimulus, and we get a little, like an echo that then bounces back to say that that noise was recognized. But what we're doing in that is we're looking for kids that have major hearing loss. Okay, we're looking for children where their hearing loss is so bad they're effectively what we would consider deaf at birth. And in that context, we're going to keep a close eye on them because they are the kids that may benefit from early intervention by means of what's called a cochlear implant. So we're measuring for really, really bad hearing loss there and then. So what that means is kids that have a little bit of hearing loss or a moderate bit of hearing loss, we'll miss them. Okay, they're not the kids at that stage that we're looking for. We're looking for the worst of the worst because they're the ones that we get benefit from as a sort of pecking order of things in terms of what we're looking at. So step number one, it's not a hearing test. Okay,
it's a screener.
That's the first important thing. The second thing is things change over time, and the most common cause of hearing loss in children as they grow and development is not hearing loss from birth. It's getting middle ear fluid. Usually, but not always, but by far related to getting an ear infection. Okay. So the 12 events is they get a cold, snotty nose, and it can drift into the ears, and they get fluid buildup. And then that fluid blocks things up. And as long as it's temporary being no more than a few weeks, then the impact on the child is negligible. There is an impact because at this sort of developmental age, they are learning a lot of things, and one of the things to learn is you need to hear properly. You need to see properly. You need to hear properly. That's part of the whole learning process. And the brain is forming connections. It's going, oh, there's an ear that I need to form some connections to. And the more stimulus into that ear, the better the connection. So if the stimulus is limited because the fluid's blocking the sound getting through, then the message to the brain isn't as active, which means the connections are not as rock solid. So one of the things we'll encounter with these children is eventually the fluid goes away one way or another, but we've missed a critical development period, which means these kids don't necessarily have a hearing problem, but they have a listening problem is how I explain it. And it's not selective hearing, okay? It's not selective deafness. It's that the ear and the brain never formed a solid connection. So as a consequence of that, even though the message is still getting into the ear, the brain is not in a position where it's processing it properly. And that's what we call an auditory processing disorder.
And what age do you normally see those kids at? What age do you normally see those clients?
Well, we can't really really diagnose it formally until they're 6 or 7. We can kind of get the gist and the vibe beforehand, but it's a very sophisticated battery of tests that you have to run them through, and that requires a bit of concentration and focus on the child, and some brain maturation and development. So usually by age 6 or 7, depending on the clinic, in the position where they can sort of be more confident about it, but you can sort of get the gist and the vibe of it. So that's one scenario just to be mindful of. In my mind,
sorry to interrupt.
Yeah, sure.
It's interesting you say that, because there are a number of clients on my caseload with a receptive language impairment, and receptive language means difficulty understanding. But even just during the course of therapy, I start to realise, given this child's had a history of ear infections, I think they're really presenting with auditory processing disorder, and then that just changes the whole intervention path of things and the strategies that need to be put in place. And it's about that 6, 7 age.
Yeah. Because with auditory processing, just to sort of try and make this clear, this is a child that can hear perfectly normally, okay? But it's the scenario where, for example, if we had some background noise, say you had the TV on in the background when we're doing this at the moment, I would still be able to sort of concentrate and focus on you and zone out that TV. Someone with an auditory processing disorder, they don't have that filter. So imagine that child in a classroom setting when it's not just, it's not a TV for starters, but it's 20 to 30 kids making noise, babbling here and there, and so forth. And then the teachers in the room, all of the above. It's trying to look through fog, in terms of the equivalent when it comes to trying to listen to things when there's a lot of background noise. But just to rewind, what I was going to say is in my mind, the best indication of a hearing problem is having a speech problem.
Yes.
And that's one of the questions I ask is to say, look, what's the story with, ear infections and hearing? Because it's not something that's an always. It's something that can come and go. And then I say, right, well, on the balance, do we tend to have more good days or bad days? And they say, oh, they're more bad days than good. And you go, all right, so you've had this hearing test and it was normal, but was that a good day? And they go, oh, yeah, actually, that was a good day. And you go, right. So that snapshot in time doesn't really reflect the movie. So you can get a normal hearing test on a good day, and that can say, well, everything works fine. And that's true. Everything works fine when everything else is fine. But if there's a child where it's coming and going instead of constant, and it's more often a problem than not, well, then that's the sort of children that we want to pick up, because it's like stop, start, 2 steps forward, 2 steps back, 2 steps forward, 3 steps back. They're sort of jumping back and forth, and they're struggling through, but they're really struggling, and we can make it so much easier for them. So what we're looking for is
that 6 month gap? Is that 6 month gap such an appropriate time gap?
No, not at all. If a child,
so you said there's a good day.
If a child is turning up with a speech problem, okay, and they've got a documented hearing problem, you've already landed on a problem. I have this new analogy that I'm rolling out that's basically saying, I'm using this a lot now. If you've got a fire in the house,
you did say that.
When's the best time to put it? When's the best time to put it out? As soon as you find it. So if you have a child with a speech problem and they can't hear properly, there's no way on earth that their speech is going to have any great sense of ability to progress and develop in that scenario. We need to save that child. That child is drowning. We need to save that child. We can work on teaching them how to swim later on. That's all well and good. But that child's drowning at the moment. We need to pull them out of the water and save them. So we need to get their ears nice and dry, optimize their hearing, and then you have a better canvas to paint on, because you have a child that can hear properly, which means they can actually act on things better.
I can do my job better. And I guess just to discriminate, there's speech and language. So hearing impacts all communication, but particularly with speech, the pronunciation of certain sounds, but also understanding words, which is the language side of things. If the child was, say, assessed today and their hearing was uncertain, how soon would you wait for a review? Would you suggest another 6 weeks?
Well, yes. So
I guess every
sometimes
case is different.
Yeah, it depends. Every child is so different. You're right. Like, if a child has a documented history where they're getting lots of ear infections, soaking up lots of antibiotics, and they've got a speech problem, look, to be honest, the hearing test doesn't matter a scrap of difference as to the fact that this child needs help. We've already got enough on the table to know that this child needs help, and we shouldn't be in a situation where we, then say, look, you're gonna have to wait a couple of weeks to get a hearing test, and then you've lost that time then to get on and see the ENT. Because as an ENT, I'm just going to go, this kid's getting too many ear infections and can't hear and speak properly. We're going to buy some time by putting things called grommets in the ears
Yes.
to give this child a reprieve to, like I said, give yourself a better canvas to paint on.
Yep.
We're trying to set these kids up for success. You can't build castles out of sand. You need rock solid foundations and then rock solid, materials. And it doesn't matter, how good you are at building a kid's speech. You cannot build
I
that
can't do
with
my job
sand.
properly. No, I cannot do my job as efficient or as properly as I can without adequate hearing. It just defeats the purpose. And I'm just moving 2 steps forward and going back.
You're setting yourself up entirely for failure.
Exactly.
You've got to set yourself up for success.
So let's assume you have a little boy who has had a history of reoccurring ear infections and he's 2.5 to 3 years of age. The mother approaches the GP and the GP said, no, there's no need for a ENT consultation. Let's wait and see, which I don't like to hear. What's your opinion on the let's wait and see perspective from a GP? How can you argue against that so they can get a referral for you?
Well, look, again, like I said at the opening, it's a tough gig as a GP, all right, like knowing everything. But there's one rule of pediatrics. Rule number one is listen to the parents. That is rule number one, okay? And, ultimately, at the end of the day, the purpose of the referral is to share clinical history and information between two professionals. And secondarily is to get some form of Medicare coverage for part of the journey and the experience. What parents need to know is that you are not required to have a referral to see a specialist. Okay, it is a Medicare requirement in Australia, but it is not a requirement. There is no requirement that says you can only see someone like me if you have a referral. Just like you and I are talking now. Okay, it's not like you needed a referral so that we could have this conversation. Okay,
not at all.
A parent that wants to have a conversation with me about their child that they're worried about, they do not need anyone else's permission to do so. Okay, they have
the GP only just has the power in the sense of to get a Medicare rebate if once they see you.
Correct.
Okay, and how much is that rebate? Did you say $80 or so?
Yeah, it's about $80 is sort of roughly what the Medicare coverage is. In terms of offsetting the cost, which again, if you weigh up, what did it cost you to see the GP to get that referral? Not only in monetary terms, but also in time. Did you have to take a day off, pull the kid out of school, take him out of daycare, and so forth? And there's an economic cost to doing all of that as well.
Time is
And then did you have to wait a while? And did you have to do that a couple of times before it was agreed to do it? Whereas in the meantime, you could have just cut to the chase. And so forth. So it's I think it's very important having professional communications. But at the end of the day, you do not need permission to see a specialist. You have absolutely every right. We live in a very free and open country. You have absolutely every right to see whoever you want for whatever reason. So if you want to come and see me and tell me about your sore toenails, well, that's your right. I can't help you, all right? But that's your right. And to be honest, we'll probably suggest you don't come and do that because it's not what I do, all right? But but that's the reality, is that you're not precluded from seeking your own help and advice from whoever you want to see for whatever reason, as long as you're being reasonable. So obviously, seeing me with a sore toenail is not reasonable. Seeing me because you're worried about what's going on with your child, and even if you think it's probably okay, but you just want that peace of mind and guidance and feedback to make sure it's okay not to do anything. Absolutely. It's not like you have to see us because there's a problem that we have to fix. Sometimes it's really like, look, I just want to know where we're at now. Sometimes I'll see someone that say, look, I've had tonsillitis 3 times. I'm not sure what to do. And we can say, look, all right, well, look, it's only 3 times. And you haven't been that sick with it, so we probably will just sit tight. And this is the rough guide. So, where the line is in the sand is. And if things settle down, don't worry. But if things flare up, at least you know when to pull the trigger. So, we can share that information with people and give them a better sense of direction. It's just like being the tour guide. It's
I love
just like,
that.
look,
I really love that, because you're working on that, building that relationship with the caregivers and the parents. Say, hey, I'm a resource. I've got this skill set. your
Yeah,
child needs support. Let's work
yeah,
together rather than having that authority figure or that power
yeah.
involved, you know?
Well, basically, like I said, you can benefit enormously from asking people like me what they know about the things that we know about, and
Empowering them.
and that's the beauty of the free country that we live
Yeah.
in, that allows that, in the private system. Now, the public system puts all sorts of barriers up to things. They don't want to see, because they've got big wait lists and long wait times,
Yeah.
so they sort of try and only see the worst of the worst, so at least they can try and prioritize things, and that can contaminate, the experiences, and say, well, if the hospital's not going to see you, then no one else is going to see you. Well, that's not true. you know
No.
um and I'm quite happy just to give people guidance and advice and reassurance too, just to, because it can be anxiety provoking for a parent.
Yep.
And you've got a child, you've got genuine concerns and worries, and you just need to know, and you just want to know, am I worrying when I don't need to, or are there problems here that need to be fixed? And
Yeah,
then that,
absolutely.
we can do that.
So how young would you, or what's the youngest you've had given grommets to a child? How young would you go?
6 days, 6 days old.
How old, sorry?
6 days.
6 days old.
Yep.
Wow. Why that young?
Some kids aspirate meconium,
Mhm.
and they get really bad reflux. So it's not just ear infections. There's rarities, and that gets into their ears. And these kids fail their newborn screening, so they
Okay.
get flagged. So they get flagged straight away, and they come up positive for fluid measurement at the time. And we need to get the fluid out as a priority, and then retest them to work out, is this kid failing in this scenario because of the fluid, or
Mm.
the fluid is actually not the full story and there is actually a more serious underlying hearing problem. So to clarify that, we need to get rid of the fluid and retest them.
So after, let's assume that the child was 2.5, they've had their grommets inserted.
Okay.
Do they fall out after, or do they
Yeah,
need to
so
be
grommets,
reinserted? Because I find,
so grommets are temporary. In fact, when grommets were first invented way back in the day, and they're pretty contemporary, but we're talking now probably like 70 odd years in the making. Initially, because they had no experience, okay, they just had an idea. Because they noticed that historically what was happening is these kids were tearing holes in their eardrums,
wow.
okay, their ear infections. People have forgotten history. History is an amazing teacher. We live in a very privileged situation now. So if we want to rewind, and let's go back before we had grommets, and even potentially before we had antibiotics. Okay, so we literally had children in hospitals on death's door dying from middle ear infections.
Interesting.
Okay,
Wow.
pre-antibiotics, the most common cause of what we call secondary meningitis. So meningitis is a really serious brain infection. The most common cause historically of secondary meningitis was a middle ear infection.
Wow.
Okay, so people have forgotten this because we don't see it anymore. We live in a very, very privileged position in history. But going back can be very instructive to sort of go, well, what did we used to have? So if we sort of work through the history of it, we used to have a situation where we didn't have antibiotics. So these kids would get serious ear infections, and if they were lucky, they would tear a hole in their eardrum and decompress the infection that way. Okay,
Wow.
so that was step one.
That's lucky.
Step two was realizing how having a hole in your drum was a good thing. Doctors quite literally would walk around the hospitals with these kids with ear infections with a tiny little stab needle. And again, this is all historical, so they would walk around with literally the little needle type thing, and they would just basically pin the kid down and stab holes in their eardrums to drain the fluid, to relieve the infection. Okay. And they weren't necessarily, sterilizing these needles in between either. They just sort of might just wipe it down onto the next one. So again, very different era in history. And that started to reduce the serious nature of these infections. But then they thought, well, if we can put something into this hole and keep the hole draining, then we'll have no more problems anymore. So that's where grommets started to come into it. And they put the grommets in, but then and initially they were made of gold or silver. They didn't have plastic manufacturing back then. They had metal. So part of the deal is that you had to bring the grommets back to the hospital. Otherwise, you would be charged for the weight in gold or silver used. All right. So parents were always checking because they didn't want to foot the bill
I didn't want to pay them
for the gold and
money.
silver. Yep. And then they bring them back to hospital, and the hospital would clean them up and use them again.
Wow.
Okay? Yeah, history's amazing, right?
It's crazy.
But what they noticed is that they were falling out, and they were going, "Oh, what a waste of time. We thought these would last forever." So they actually stopped doing grommets, thinking it was a waste of time. And then they stopped, looked back and gone, well, hang on a sec. Most of these kids, when they fall out, are absolutely fine. And when they were in, they were really, really good. And there's a handful of kids, when they fall out, they start to get problems again. Maybe we just need to put them in again. Some kids need them more than once. So over time, we sort of refined things, and we transitioned from gold and silver to plastic. So most, the grommets these days are plastic. And we pop them in, and they fall out over a time period, usually a couple of months. And for about 90% of kids, it's just a time buying exercise to get them out of trouble, and job's done, and it's onwards and upwards. But in the small group of 10% of kids where they fall out and things continue to play up, we just put them back in again. We just buy more time.
Yeah. Interesting. That's really, really interesting. So the child has the grommets, they fall out, their communication starts to develop. Would you then see them again for a consultation, or
so
just let them be and have fun and develop their language?
I get them to have a hearing test about a month afterwards, just to confirm. Every now and then, maybe once every 2 or 3 years, we'll come across a kid where it wasn't just fluid. There was actually an underlying additional hearing problem. And then we need to say, look, the grommets are not going to be enough here. We're going to look at, hearing aids or whatever, to then supplement the rest of it. So we get the hearing check done in a month, just make sure everything's going okay. And then I'm quite happy. The GP can just check the grommets every few months. And then when they fall out, there's 2 scenarios. Everything's perfectly fine, or there's problems again. If there's problems again, we'll do grommets again.
Yeah. So I guess the take-home message from that is your child's not communicating effectively. They've had a history of ear infections. You don't need a GP referral. Follow your gut. Contact an ENT.
Ideally, but if you're meeting roadblocks and you're not getting the answer you want, because you're not getting a piece of paper, you do not need that piece of paper as permission to see someone like me. That's
That's
not
nice
a law.
To clarify that.
It's not a law. You got every
I think
right
it's this misconception that you need to get a referral. Like a lot of my caseload, well, I'm going to the GP to get the enhanced primary care plan or the chronic management plan and a GP referral and a referral for you. It's like, no, you don't need one.
Well, again, that's just a reflection of what the system says you need to do. In some countries, you don't. There's no such thing as a referral. It doesn't even exist. Like I've worked in New Zealand. You don't need a referral. You just call up the specialist. They want to come and see you. It's a conditioned belief, because of the system that we've got. But it's not a law. It's not a rule.
Clients claim your services under NDIS or private health?
No. Okay. So, well, let me rewind. You asked me 2 questions there. NDIS, no. NDIS is to cover those things that, the Medicare system doesn't cover. Okay. So, people like yourself, that sort of thing. Private health cover does not cover anybody at all for medical things outside of hospital. It only covers you if you're in hospital having things done. So private health for hospital cover is only for hospital cover. So again, seeing me in the office, whether you got health insurance or not, makes zero difference, because there's zero health insurance coverage in that scenario, because that's what other people get told. They said, "Oh, you haven't got health insurance, so you can't see the private specialist." That again is not true. It's just
does Medicare also claim? Sorry to interrupt you. Does Medicare provides rebate for the grommet insertions, or is that just a private fee as well? Okay.
So when you go to hospital and have the anaesthetic and the surgical procedure parts, not the hospital part, the anaesthetic and the surgical part of that is covered by Medicare, and there's additional coverage if you have insurance. Okay. What the insurance mostly covers is the hospital part, and it is a little bit of a supplement to the anaesthetic and the surgical part.
And do you need the GP referral for that element, or just your consultation's enough?
Not for ENT procedures.
Okay.
So some procedures you do need to have a referral if you're having a procedure in hospital.
Yep.
But again, the ENT you don't. There's again a misperception. But if you don't have the referral, you will not be able to claim against your health insurance necessarily.
Sure.
They
understand.
may insist on a referral, but Medicare doesn't.
So I guess just so people can understand, you don't need a referral for the initial consultation, but if you do have a referral, you do get a slight rebate back between $70, $80, obviously pending your fees. But then for the procedure, that's a whole new can of worms that you can deal with. Okay, so I found this really interesting. Now, what I'm really more interested in is your interest and topic into snoring. Childhood snoring and airway, and the link to what you believe could be associated with ADHD. That's been increased lately with the number of children being diagnosed with ADHD, especially when they're quite young, between 4 to 5 years of age. What's your point of view? We'll start from the beginning. What's your perspective on airway and snoring and breathing and so forth?
Yep. So just to put things into context, let's just cut to the chase. A child is not supposed to snore. Okay. They're not supposed to mouth breathe, and they're certainly not supposed to stop breathing when they're asleep. Okay.
Can you show a visual of what a mouth breather is? Because my daughter has a tongue thrust, and I never knew that she had one.
That can be
so quite
open.
Open.
But it can just be just lips just apart a little bit. They're not supposed to be there sitting breathing through the mouth. Okay. Now there's a few exceptions to the rule. It's okay if they've got a cold at the time, because that's just a circumstance and situational thing. It's okay if they've had a massive day and they're just completely smashed and completely wiped out, and they're just crashing and burning and snoring away. That's easily explained. That's just circumstantial. What we're talking about is things that are there that are persistent. So mouth breathing, snoring, stopping breathing at night, bad, and bad. Okay. They're just different degrees of bad. Okay. So but they're all in the bad category. Okay. And the thing that then really escalates it is if it's impacting on their sleep quality, and your biggest clue is waking up tired. Okay. If the child is waking up tired, there is either a sleep quality problem, a sleep quantity problem, and or an underlying potentially serious medical condition to boot. Okay. So waking up tired in the morning is a super big red flag for kids and adults for that matter, but particularly kids. Okay. The reason that snoring, mouth breathing, and stopping breathing at night is all in the bad category is that they're all a sign of having a breathing problem. Now, when you have a breathing problem, you have an oxygen problem. Okay. And the problem in children as to why that is such an important thing is got everything to do with their brain. Okay. So there's two things that the brain absolutely needs. It needs oxygen and it needs energy. And it's actually a greedy part of the body, because every time the heart pumps blood, 20% of that blood goes to the brain. Okay. You look at how big the rest of your body is, and the brain is taking 20% of every heartbeat. And that's because it is desperate for energy and desperate for oxygen. And if there's any interruption to the oxygen flow and supply, there's a brain problem. Okay. And that's what happens to these kids when they're snoring or mouth breathing or stopping breathing at night, is they're not getting adequate oxygen to their brain. And the thing about their brain that makes it different to your brain and mine is their demand. Their demand is much higher because a lot of learning comes from sleep. So all the things that we're talking about now is going to be parked in the brain, and you're not going to remember what I said 5 minutes ago if I was to ask you, but your brain is basically putting it in there into the storage bank, and tonight it's going to process it. And what it's going to do is the bits that I've said along the way that triggered a little bit of an oh wow moment, it's going to hold on to that, and then it's going to get rid of the rest. So it's going to forget down the track what colour shirts we were wearing, except I just said it now, so now the brain's going to go, what colour shirts are they wearing? But until I said that, you weren't paying attention to that. But there's a lot of things I have said.
I was actually just thinking of all the mothers asking their child if they're tired when they wake up in the morning, just because they're probably thinking, well, my child does snore. They've fallen asleep in the classroom a few times. Maybe there's an underlying issue rather than them actually being just generally tired. There's something else going on.
Well, it's a sign that they've basically, like I said, the brain hasn't had the sleep that it needs. So what happens is that the disrupted oxygen supply interferes with the sleep patterns. So when we fall asleep, we follow like a little journey, all right? And we go from A to B following a certain preordained pathway. And if that pathway gets interrupted, we get lost. We sort of have to go back and start again, and we get a little bit disorientated. Yes. And in medical terms, that's what's called an arousal. And it's usually not so bad that the child wakes up, but the worst ones do. Okay, so the really bad kids, they actually wake up, and they're the kids that wake up through the night and then come into the parents' bedroom because they've woken up. So between those two things, the oxygen and what we call the arousals, that interferes with the sleep and the sleep patterns, which mean the brain didn't get its recharge. So it'd be like you putting your mobile phone on the charger and then waking up in the morning, it's at 3%.
Yeah.
You know you've got a problem with the charger. Something's not happening properly. And your phone is not going to get through the day. It's going to crash and burn.
Yeah.
It's the same with these kids. So if you're starting the day off tired in the morning, you're off to a bad start. Okay.
Absolutely.
So that's to be mindful. And then the other clues, that can be the kids that are tossing and turning at night. They're just super restless, or they're sweating, or they start sleepwalking or sleep talking, or get night terrors, or they're grinding their teeth at night. They're all red flags as well. These kids, when it's happening, part of what the body does to compensate is it makes the heart pump harder, and the body's stress hormones go up. And that combination of things can lead to their blood pressure going up, which leads to more fluid going through their kidneys, which means more fluid in their bladders. And then they start, potentially wetting the bed a lot. So that can be another sign. And then they wake up in the day, and this is a really important thing to understand because it can go two ways. The most common way it goes is the kid wakes up tired, they're slow to start, takes them a while to sort of catch up and get refreshed. And then during the day, they can have behavioural problems, concentration, emotions, energy levels, these sorts of things. The other way it can spin, though, is the brain does different things, okay? And there's a relatively new part of our brain called the prefrontal cortex. When you look at, other parts of the brain, evolutionary-wise, it's a new part of the brain. And its job is to just keep a check on what you're doing. So it's the reason why you and I are, talking to each other at the moment, and we're sitting still, and we're wearing clothes. Because our prefrontal cortex says you can't turn up naked to this, it's just not on. We're sort of doing socially appropriate things. In children that are snoring or mouth breathing, having sleep apnea, in terms of the oxygen effect, the prefrontal cortex is one of the most vulnerable parts of the brain in terms of what can happen. And what happens in these kids is that part of the brain starts to switch off. So the analogy is like a car with with a brake and an accelerator. And it's not that these kids have extra energy. What they have is unregulated energy. So they don't have their foot on the accelerator. They just don't have a brake. So there's nothing to slow them down. So the relative observation is these kids are hyperactive, correct? And their concentration and their focus and their behavior, and they're just inappropriate, and they're just, fidgety and stuff. All those things are a reflection of brain function. And if it's with the fact that they're not breathing and sleeping properly, then you've got to make sure that you're dealing with the right problem. And what we've known now for close to 20 years is that somewhere between 25 to 50% of kids given a diagnosis of ADHD are actually in the category where they're not breathing and sleeping properly. And a lot of those kids are completely different kids when someone like me sees them, work out what's going on, gets them fixed, and we're back on track. The problem is just realizing that this is a problem.
So firstly, why the urgency for such a diagnosis at a young age? Why not go through a systematic approach where they deal with their pediatrician or their psychologist and then think, okay, a characteristic of ADHD is possibly sleeping difficulties. Let's consult with an ENT to outrule that first before we diagnose this child. Why? Is there some sort of system like that in place?
This is where the parents have to drive the bus a bit. Okay. Because effectively with these children, if they end up on, the ENT level of the hospital, well, they'll see someone like me and we'll get the ENT stuff sorted if that's appropriate. Whereas if they land, on the ADHD level of the hospital, well, they just get treated as an ADHD kid. Okay. So where the parents need to sort of have this information and drive the bus. So simple question. If your child is snoring or mouth breathing, stopping breathing at night, the first person you need to see is an ENT, because the majority of that clinical presentation falls into the category of things that we can diagnose and fix appropriately. And it's not to say that, you know, in doing so, every kid's ADHD is going to disappear, because
but the behaviours will get better.
There's no reason that they can't have
Yeah.
both. Okay,
Yeah.
you can have both. You can have both going on. You can have one or the other or both. And in the scenario where it's both, well, at least the ADHD part is less of a problem, because the whole breathing and sleep thing is fuel on the fire. It's kind of one of those scenarios where 2 + 2 = 7. You know, we take the ENT stuff off and make a dramatic improvement. Maybe not a complete one, but, you know, we've got to do right by these kids by making sure that we don't miss anything.
But I guess what's also quite concerning is that some pediatricians aren't even thinking about breathing difficulties. They're going straight to the diagnosis, which is quite misleading and quite not empowering for parents at the same time. So I guess, is there an allied health nurse or another type of system they can access to then say, let's try this out?
Honestly, the thing that makes the biggest difference is conversations like this that then lead to parents telling other parents, other parents.
Exactly, word of mouth.
We've just got to basically get this, you know, what I'm doing is I'm throwing a little stone into a massive lake, and realistically, we're going to get a little ripple next to where that stone hit. You know, and this might trickle just a little bit, okay? But that massive lake of ignorance and unawareness mostly gets untouched. So what do? Just keep throwing stones into the lake, and I just find different spots, and it starts to see, and it starts to have an effect, and then you know you got yourself, but you know I do these things with teachers and OTs and you know anyone that's got an interest and potentially touch point with these kids, dentists, that can potentially sort of see these kids and go, hang on a second,
something's up.
This kid's got really dark circles under their eyes. I thought it was just because this kid was up till 10 o'clock at night watching TV and YouTube and playing video games, which certainly doesn't help, but maybe when you finally do get to sleep, does your kid snore or mouth breathe? And parent go, oh yeah, it's really cute. And you go, maybe not.
Just like his dad.
Exactly. Just like dad. You go, well, how's dad doing? Dad gets so tired and grumpy, and he's you know exhausted by the day. So dad's not doing too great after all turns out either. All right. So we've normalized a problem and sort of made snoring cute. It's not cute. Your child choking. That's not cute.
And is a child choking or snoring as a result of enlarged adenoids or tonsils? What other contributing factors are there?
There's a host. The problem is that there's actually a host of things that can cause, you know, the snoring and the mouth breathing. The majority of it is what you referred to. So tonsils are things at the back of the throat, adenoids are things at the back of the nose. That definitely is the majority, but it's not the entirety. It can be due to nose problems. It can be due to lower throat problems. It can be due to tongue problems. It can be due to jaw growth and development problems. It can be due to muscle tone problems. So my job is to know the everything and then put the child through an assessment to see, all right, of all the things this could be, what do we got? Which bits is my job to fix? Which bits belong to the speechy? Which bits belong to the dentist, etc. So that basically, you know, we bring in a team. We surround this child with a team of people to collectively then help them be the best version of themselves that they can be.
A multidisciplinary approach. Now, at what age do you raise concern? Should parents be concerned of their child snoring? As young as 1 or even younger?
Day 1.
Day 1. Wow. Day one. Wow. Okay.
Noisy breathing is not normal. Struggled, laboured breathing is not normal. Mouth breathing is not normal. You know, most of these kids we see sort of 18 months and on, but most of these kids is not all these kids. You know, the youngest kid that I've done adenoid surgery on was 5 months of age. The youngest kid I know of having their tonsils out was 6 weeks of age. Okay.
So I never knew you could start that young. I always thought around the 3-4-year-old range is probably the best age because of their weight, their age.
I'm going to unpack and destroy that one because when we look at the science, okay, the children that have the worst outcomes, there's 2 things that define bad long-term outcomes. One is the age of onset, and 2 is the duration of disease. Okay. So in terms of the age of onset, the children, when we follow and watch what happens to the children as they grow and develop, even with appropriate interventions down the track, the children that have the worst long-term outcomes are the children where their problems start under 18 months of age. Okay. So those children are the worst of the worst. Why? Because their brains is in a super developmental stage. Walking, talking, feeding, etc. Super developmental age. Huge bit of neuroplasticity being exercised. So children with age of onset, under the age of 18 months of age, have the worst long-term outcomes.
Okay.
Second, duration. Any child, regardless of age, where they've had the problem start, once that from that time point to 6 months, anything beyond 6 months have the worst outcomes. All right. So we have an age-dependent variable and a time-dependent variable. So fixing these kids at age 3 or 4, if it started at 1, is an absolute disaster for them. 1, because it started young, and 2, they've been let go way too long.
Okay. It's really interesting because now, at least from my case history, I can definitely ask how long has your child been snoring for, what behaviours have you noticed, and then it's an immediate referral to an ENT to further investigate this. I have many people are asking questions. Are you open to answering them? Or okay.
We'll just emphasise that this is general information. We're not diagnosing. We're not treating.
No, it's just general. And it's just it's not. No, and if they want to talk to you in more detail, book a consultation. You don't need a referral. So the first question.
So topics of interest. Go for it.
But you don't need a referral for from your GP. Only if you want the Medicare rebate, which is a certain amount, but that's fine, $80 or so. Okay. Can any key articles be shared that UK ENTs would take on board in terms of strong evidence for removal of tonsils and adenoids to be removed in cases of possible OSA and excessive congestion, mouth breathing?
All right, let me make this easy for you. First up, I've got heaps of articles on my Facebook page. I can't link them to the Instagram page. So if you look at Dr David McIntosh as the Facebook page, every day I put an article up. So that's the first thing. Second thing, if you're trying to do this through the NHS, give up now. It's a dead end. Okay? It's just the system is so backwards, it's terrible. Third thing, there are 2 countries in the world that stand out amongst the crowd in terms of this being a problem, in terms of lack of interest, lack of being proactive. One is the United Kingdom and the other is Canada. Okay? All right? So basically what I cannot do is try and convince someone that their religion is wrong. Okay? If their belief system is that we don't need to fix these kids, I can't change that with any degree of information any more that I could turn up on someone's doorstep with some form of religious book and convince someone that being part of my religion is a good idea. So if you're having to change someone's mind about something, you're already seeing the wrong person. So what you need to do, unfortunately but realistically, is you need to try and work out who is that person that you need to see and just go straight to them. Otherwise, it's kind of like landing in a new city and trying to find your way around with, say you land in Rome and you're trying to find your way around, but all you've got is a map of New York. You're in the wrong place for the wrong thing. So what do? Well, you ask around for the locals for help and advice and direction. And if they say, no, the place you're looking for is way over there, you're in the wrong place, well, go to the right place. If it means you've got to get up and travel, you're much better doing that and just being an advocate for your own, well-being, rather than trying to fight a system that's already showing that it's not interested in you.
Yeah, understand. No, that's useful. Thank you. Next question. If my question has had grommets inserted and adenoids removed, but mouth breathes during the day sporadically, should we get him checked?
Number 1, yes. And number 2, if I can be a little bit self-promotional, because part of the way I found it's useful to share information is to write it down. And I've put it in a book. So if you jump onto Amazon, it's called Sleep Disordered Breathing, A Parent's Guide. I actually explain and cover that scenario that can eventuate so that the parents know what they need to be aware of, so that when they're getting that review, that the boxes that need to be ticked are being ticked comprehensively, as part of that journey. So I have that exact specific scenario in the book as one of many, so that parents have got their little roadmap, so that when they are turning up into New York, they've got a New York roadmap that tells them how to get, from A to B.
Yeah, okay. And that's just available on Amazon?
Correct.
Yeah, okay. Now this is, I think, a medical type of question. I use the Children's Sleep Disturbance Scale to show the ENT's red flag for OSA. Anything else MR recommends to give as evidence to get an ENT aware of severity? I also do a sleep video.
Again, if you're having to convince someone, like you're having to go to all convince people, you're trying to convince the wrong people.
Yeah. There's a lot of evidence there just to try and justify a cause, isn't it?
Yeah, if you're trying to work with people that you need to try and convince, you're kind of doing the wrong thing. You're fighting the wrong battle. You're much going to you have a smoother progress. You go, I can send you this person who's going to need a lot of convincing. Oh, I already know what the problem is. I think I know what needs to be done. This person actually concentrates and focuses and specialises on it. So they're going to know best of the best as to, what to do. Do you want to just see the person around the corner because they're there, or do you want to go and see this other person and get something a little bit more certain?
Yeah.
And that's a choice.
Interesting.
Again,
That's true. No, that's true.
That's a choice.
This is an interesting question, because I don't know why a parent would want to monitor their child's sleep. So they're asking, what's the best app for parents to monitor their child's sleep? Firstly, why would a parent need to monitor their sleep? Shouldn't they just do a sleep study through the hospital? So she's asked Fitbit, or a Ring, or a Snore Lab.
Okay, none of the above is approved for use in Australia. So they have zero approval for use in children and adults, for that matter. They are not medically approved. They are not accurate enough to meet the criteria for medical assessment. They're a guide at best. First of all, what do I tell parents to do? All right, so they ask, what should I do? Well, let me tell you what I tell parents to do. I tell parents to go into the room of the kid every night for a week or two and look for snoring and mouth breathing and stopping breathing at night. And if that is going on, you've got a problem. You don't need to measure it. You don't need to monitor it. You've already found the problem. Then it's my job to work out the why. We've already got the what. We need to work out the why. In the process of doing that, why do parents need to do it? Because often they've got no idea. You put the kids to bed. They're down one end of the room. You're down the other end of the house. You've got no idea what's going on. All you know is you put them to bed, and then in the morning you're struggling to get them up and get them moving. You've got no idea. And it's not until, maybe you go camping or you go on a family holiday where you share a hotel room or something, and then you go, oh my God, we had no idea. And it's just like, well, why don't you try and find out, by deliberate action rather than by accident? And to do that, you go and check it yourself. Yeah. So that's the first thing. The second thing that you mentioned is a sleep study. Now, sleep studies, first of all, do not tell you the cause of the problem. And sleep studies only find the worst of the worst. So you could
like the initial hearing screener.
A normal sleep study does not mean normal breathing. Okay, so you can have a perfectly normal sleep study if you've got big adenoids and your mouth breathing, because by breathing through your mouth, you're actually bypassing the obstruction. So when they measure for an obstruction, they don't find one because you're actually working around it. But mouth breathing is not good for you. So, being a mouth breather is actually, it actually is an insult. If you look it up, calling someone a mouth breather in certain cultures, particularly the American culture, that's actually an insult. It's like calling you a dumbass. It's an insulting term. So those of you that have watched on Netflix Stranger Thing, they use that term as an insult amongst the kids talking to each other, go mouth breather, mouth breather. It is an insult term. But again, it just shows you how we've normalized things to the point that, in this country, it's not even considered, an insult for starters. But on top of that, it's not normal. So I don't, I can count on my fingers and toes with spares how many sleep studies I've organised in 20 years for these kids. The only reason for doing a test is because it changes management. And if I've got a kid that can't breathe properly, I can see that they're blocked. 2 and 2 is already 4. Sleep study is not going to anything about that child that is going to guide me to the fact that I need to help that child.
Yeah. Interesting. Thank you for that. That's really insightful. Got that. I think there's just a review about you, how amazing you were with her child. So thank you. That was from Nick08. Why would my child have enlarged tonsils without being ill?
Okay.
That's a good one.
Most children with enlarged tonsils have zero history of being sick. Okay. So if we look at ENT, okay, if we look at 80% of the reasons we do things falls into two categories: infection or obstruction. Okay. So for example, if you were to get into a fight tonight and get your nose broken, okay, and now you can't breathe through your nose, I'm not going to say, well, I don't need to fix it because you've never had a sinus infection. Okay. Like, it wouldn't even cross someone's mind that you would need to do that. It's just like, well, clearly it's been broken. I can't breathe. I need you to fix it. Okay. So this is where people trip over themselves when it comes to tonsils, is because in people's mindset, the reason that we take out tonsils is because of infection. And that's totally true. But 90% of kids' tonsils that I take out have a zero history of tonsillitis. Okay. So it's got nothing to do with infection. Some kids get both, but most of the time what's happened in these children is it's actually not driven so much by a bacterial infection, which is mostly what tonsillitis is, but it's driven by viral processes. So, normal colds, infections, those sorts of things, they seep into the tonsils and the adenoids, and they generate an immune response, which usually kills the bugs off, but usually is not always. And in some people, that virus actually, works its way around the system and gets to take up residency. Now, the body keeps fighting against it, but the body never wins. In the process of fighting it, it basically, recruits more tissue, which means the tonsils and adenoids start to grow and get bigger and bigger and bigger. And it's got zero to do with tonsillitis. So that's the other pushback that we get. And they go, well, they've got really big tonsils, but they've never had infection. To which my answer is, so, you've had your broken nose and you've never had a sinus infection, so it's got nothing to do with it. It's the same operation, but it's done for different reasons. Okay, it can be because of obstruction or infection, and 90% of it, it's because of obstruction. All right, and there's no medicine in the world. There's no other. I wish we had a magic pill, and maybe one day we will. But the reality is, we have a child whose brain is suffering because they can't breathe properly. You want to keep those tools and ruin the brain, or do you want to save the brain? Save the brain.
Yeah, save the brain, absolutely. Okay, and there are many questions. I'll just read two more questions because we've been here for quite some time.
I'm happy time-wise as much as you want to spend.
Yeah, I think let's give us another 15 or so minutes. And then if anyone has any direct questions, by all means, just contact you and book a consultation. Yeah, exactly. Do you offer virtual ones like Zoom?
And read the book. Honestly, I'm so used to, these questions just coming up again and again and again.
Yeah.
I've put it in the book just to try and basically give parents that little instruction book that they never got.
Yeah, of course. So someone just made a comment. David, the problem is when we refer children younger than 2 years of age, most of the ENT specialists won't accept the surgery or treatment. Why are you a different ENT?
Well, then you need a different ENT.
Yeah. Let's get another opinion.
Like if I get a referral for, an adult ear problem, we'll tell the patient, look, I can see you, but I'm just going to be sending you someone else. So why don't you go somewhere else? Again, if you're to convince people to do things, you've got to find those that you don't need to convince. And that may mean that you have an ENT that you send the 2 and overs to, but you've got to find a different ENT that you send the under 2s to. So that way you've just got a slipstream, straightforward process that, you make life easy for yourself. Find the people that can help you with the problems that you want sorted and just work with them. It doesn't have to be one person. Get a team of people.
It's like when you're going to buy a car, you go to different dealerships to get the better price. So just go to a different ENT that resonates with you.
If you go to a Toyota dealership, they're not going to, try and sell you a Ford.
No.
And so forth. So, even though, maybe that's what you need. You've got to find the right people for the right problem.
Yeah.
And you cannot expect everyone to be that solution that you need. So you get a team of people. That way when you have the parents go, okay, this thing I'm going to send you to that doctor, but this one I need to send you that one. They're both ENTs, but this one does this more than that. So that's why I'm choosing that one for you. I know the other one's, around the corner, and you probably had friends that have gone there, but this one focuses on this more. So that's why we sort of pick and choose, depending on what your problem is, as to who we suggest might be best option for you.
Yeah. Just for my interest, when you mentioned it could be the obstruction or
Mm.
infection for the enlarged
Well,
tonsils or adenoids,
in
can
terms of the
difficult.
reason we do surgery, the reason we do
Oh,
surgery is
okay.
to remove tonsils. So you could have lots of tonsillitis and tiny tonsils, or you have
Yep.
zero infection and massive tonsils. Both those
Okay.
scenarios, the tonsils are going to get pulled. All right. So on paper, the procedure is the
Mhm.
same, but the indication, reason that we do it is very different.
Different. And is swallowing difficulties another indicator if a child
Absolutely.
can't say swallow? Yeah, I thought so, because that's one of my
Yeah.
questions that I
Yeah.
ask. How are they
Because you've got
swallowing,
to realize
especially on solid?
it's not just an airway, it's a
Mm,
foodway.
mm,
You know?
mm,
And if they're
mm.
trying to wash food through something that's
Or
blocked,
even changing their swallowing maneuver just to
yeah,
help them out.
yeah,
Yeah, yeah, yeah, yeah. It's pretty
yeah,
obvious.
they're trying to force it down.
Or even if the parents are modifying the size of the food for a 5-year-old,
Well,
even the
that's
texture of
what
the food.
they do. Kids are survival machines, so they work out what's easy and hard. So,
Yeah,
common scenarios. These are the kids that you'll give them a piece of meat, they'll chew it for a minute or two, and then
yeah,
they'll just spit it out.
yeah, because I can't
But
swallow it.
mince stuff, and it's not a problem. It's not that they don't like it. It's not that they don't
Mm,
want it. They know what's
mm.
harder, and they
They'll
choose
avoid
their
it.
battles. Yeah.
Yeah, they avoid it. This is one's interesting. Do you know if there's a genetic link to enlarged adenoids?
Yes, there is. So when we look at like across the board, just in general, all right, and this ties in with tonsils, allergies, the works. The general background population rate of this type of problem is actually really high. It's about 1 in 5 children. Okay, it's about
Mm,
20%. Okay, so that's just random kid on the street. There's a 20% chance that they've got these sorts of problems. Now, if you have a child from a family and they have a sibling, okay, brother, sister, older, younger, whatever, their siblings are at a 50% increased risk of having it. Plus, there's a 50% chance that one or both of their parents had it as well. And there's a 50% chance that their children will have it down the track as well.
wow.
Okay. So there's definitely a genetic component where if you've got one kid, okay, that could be just a one-off bad luck thing, but it does raise the stakes significantly that the other kids are also going to have the problems too. It's
So
not absolute.
do you have like a buy one get one free deal when you're getting
Oh, well,
adenoids
you get one
removed or tonsils removed?
No, but look, every kid is on their own merit, and sometimes kids will turn up, with very similar stories and have very different outcomes in terms of the cause and the fix.
Yeah.
So some kids will be tonsils and adenoids, and that's surgery. Other kids can be like, oh, this one's actually getting really bad hay fever and
Mm,
congestion, so that's going to be a
mm,
medicine to try and fix it.
mm,
So you can present with a spectrum of things as a cause, but a totally similar way that they look.
mm,
So every kid
mm.
is there.
I've just got a curious question. Teeth grinding, what's the association?
Okay, so when it comes to teeth grinding, the most common cause is having a breathing problem, and it's
Mhm.
triggered by low oxygen. So
Okay.
what happens in that scenario is they get the low oxygen first.
Hmm.
The brain goes run out of oxygen, sends a message. The message basically is the heart pumps harder and faster. One of the
Hmm.
consequences of that is the blood pressure goes up. And there's a
Hmm.
little pressure monitor in the big artery that comes out of the heart.
Hmm.
And if it's under too much pressure, it will send a signal back to the brain that says, calm down, you've overshot, so it tries to self-regulate. One of the side effects to that is it has an interplay with the nervous system to the nerve that comes out to the jaws, that muscles that move the jaw. So basically what
Hmm.
happens is they basically get the oxygen drop, then there's a little pause and the blood pressure goes up because the heart rate's gone up,
Hmm.
and then there's a little pause, and then that little pause, went too high, come down, and they start grinding their teeth. So they follow that
Sure.
sequence. So the
Mm.
most common cause of teeth grinding in kids and adults for that matter at night when you're asleep is low oxygen. The
Okay.
second most common cause is low iron.
Hmm.
The third most common cause is nasal allergies. And then the distant fourth is a tongue tie. And then
Yeah.
a distant fifth is sort of other, just other things. The big one is
Mm.
breathing, followed by iron, followed by hay fever, allergy type stuff. The
Hmm.
problem is having a snoring, mouth breathing type scenario going on also affects the gut to the point that it can affect iron absorption. Plus, as we just said, maybe these kids aren't eating so much in terms of meat and
So
iron-rich
can swallow.
foods, so they
Yeah.
with low iron there. Low iron also makes them tired. Okay,
Mm.
allergies can also muck up the gut. So in hay fever scenario, that's what we call an inflammatory disease. There can be an overflow that affects the gut, and in about 25 to 30% of people in general, kids and adults, that can be enough to affect iron absorption. And where this gets really, pernicious is that low iron makes allergies worse. So you can get an allergy that mucks up your breathing, mucks up your gut, mucks up your iron, and then the iron makes the allergy worse, and then you call it a vicious circle. So when I come across these kids, any sign of hay fever, allergy stuff, I'm checking their iron. Any teeth grinding, I'm checking their iron. And the iron blood test results, in terms of the numbers, unfortunately, are wrong when it comes to teeth grinding. The reason for that is the reference range is related to the risk of developing what's called iron deficiency anemia, which is a serious medical problem. The problem is there's a grey zone that sits between what that cutoff is and what we're aiming for, where the iron can be what we call functionally low, but not seriously low. So often the lab results will have a cutoff of either 20 or 30. Anything under 20 or 30 is considered low, depending on which lab you go to. So you might get the feedback and go, oh, your iron was fine, it was 35, it was normal. Now, technically, that's true on the reference range. We're actually aiming for 50, though. So if a child that's got, anywhere that's under 50 is a problem. Now, I use 45 in my cutoff. I think between 45 and 50 is being a little bit over pedantic. But as soon as we're 45 or below, even if it says it's normal, it's not in this context, because we're not, they're normal in terms of their risk of iron deficiency anemia is way away from us. They're still in problem territory. So, yeah, so that's teeth grinding in a nutshell. Often the dentist, but it is not a dental. It has dental consequences, but it is not a dental problem.
Yeah, far more complicated than what I thought.
Oh yeah. We're going into the weeds now.
There's only one more question, which is great. So, can a large tongue cause mouth bleeding in a 3-year-old? And if so, how do you remediate this?
Okay, so when we talk about large tongue, it gets a little bit tricky because there's a few rare conditions that create a genuinely large tongue. Okay, so a large tongue in medical terms is called macroglossia. So just to break that down, macro means big and glossia is tongue. So big tongue is called macroglossia. So we have what's called absolute macroglossia, which is the tongue is just enormous. Okay. But most of the time we have what's called relative macroglossia. And what that means is, in actual fact, the tongue is actually a pretty normal size, but the space that it's inside of, the oral cavity, is too small. So the tongue is relatively speaking, too big for the space. So it looks too big, but that's because there's a problem with the space. And in that scenario, we actually look at the space more than we look at the tongue. The tongue's the obvious, we look at the space. And the space relates to how the jaw's developing. And abnormal jaw growth and development, as I said, way back, is part of the dynamics of this whole breathing and sleep thing. And mouth breathing in particular has a significant impact on limiting jaw growth and development. So it's one of the, again, reasons you go, all right, the observation is mouth breathing. The secondary observation is a big tongue. That's probably, not definitely, because like I said, we're not diagnosing here, but that's probably because there's a problem with the jaws, which ties in with the mouth breathing, which, long story short, means go and see an ENT. You know, this is, again, people will spend weeks, months looking up stuff, trying to do their own research. And I'm just
wasting time.
At the end of the day, you can do that if you want, or you can just cut to the chase. If there's a fire in your house, you can Google and look up how to put out a fire, or just call 000 and let the people that do it come in and save you. It's the same thing. I totally understand parents' desire to want to know and learn and educate themselves, but at the end of the day, you're never going to meet the level of knowledge that someone like me is walking around. And I'm not being arrogant, I'm being realistic, because at the same time, I'm absolutely useless at fixing a car. I've got no idea. Wouldn't even know where to start, talking car. I'm complete numpty when it comes to it. Why? Because it's not what I do. What I do, I take it to the mechanic. I get it serviced. They give me feedback. They go, well, we found this, this, and this, and we just got on and fixed it. And I say, thank you very much, because it means that I can continue my car. I'm not going to break down. I'm not going to have problems. And I know that everything is working properly and it's safe. That's their job. Well, it's the same for us. We have this, unique part of history where the access to knowledge and information is phenomenal. But at the same time, our ability to filter it is still very, very primitive.
Yeah.
And it's very easy to read things online and think that you know it. But the reality is it's easier to fool someone than convince them they've been fooled.
And how appropriate and ethical is the information that they find? Is it the true evidence-based practice, or is it could be someone on TikTok who wrote it? Yeah.
So I'd like to think that the stuff that I put there obviously comes from a position of being well informed and knowledgeable, and skilled at working out what's real and what's not.
Yeah.
But it's also why I'm not running an information page on car mechanics. I wouldn't know. Read something and put it up, and a mechanic would just go, "I've got clearly no idea what you're talking about, mate. Probably just stay in your lane." So again, unless you know the source and so forth, it is so easily to be sort of go down rabbit holes and misled by people that have got agendas. My agenda is very straightforward. My agenda is to share the knowledge, share the information, and then let people reflect on that and decide if they think that what I'm sharing is coming from a good place, versus people that are out there that will try and sell mouth breathing therapies and
or even molds or something for their mouth.
Behavioral therapies and sleep training and all the things that have an agenda behind them, which when you go into the sort of science and so forth, which is what I do, I live on the science. That's my foundation. And I just keep building it and building it and remodeling it and so forth, and renovating it. So it just keeps, getting bigger and better for my benefit, but also, for everyone else too, to, share the journey.
Yeah, and I guess this is why I've also created the Wine with Wita platform, just to bring such informative guests like you, just to put the word out there. Just simply, if your child's snoring, that's a big no-no. And I'm sure many people would tell their family members or their friends, if your child's snoring, just go see an ENT. And the power of word of mouth, of just knowing that little bit of information is so powerful
like I said,
for many families.
We had, 15, 20 people, all right? Those 15, 20 people have the opportunity to obviously absorb it for their benefit. But they can then tell just one more parent, and we just doubled the numbers.
That's enough.
And then those, maybe that, they'll tell someone else, and we just tripled our numbers. That's that ripple effect. That's why I do it. There's no point me having the information just for me. It's important that I have it for me. I think it's important for everyone to have it.
Yeah, absolutely. So how can people access you if they need to book a consultation? I know you're based in Queensland and Sydney. Is it Neutral Bay that you're based in Sydney?
Correct. Yep. So Neutral Bay. Correct.
And what's your practice called? Is it they just go to your Instagram page?
Yeah. So if they look up for Sydney on the Facebook page, is ENT Specialist Sydney. But again, we've got the website entspecialist.com.au. Just go, old school website. I mean, who uses those? Who uses those these days?
Google Dr. McIntosh, Dr. David McIntosh. That's enough.
Yep. And you'll see the online reviews and stuff, which I've got no control over. And some people don't like me, and that's okay. You can't please everyone, and so forth. But most people are happy, and that's all I can hope for.
As I tell my daughters, you might be too much for some, but you're enough for others. So just live by that and do that. Dr. David, I am so grateful for you and the information you have provided myself, other colleagues, and my platform. It has been incredibly informative, and you've left me with lots of questions now to ask clients when I meet them for the first time. And you're definitely on my first referral source. Just go see Dr. David and tell him, Rita or Rita's referred you, because I really believe in empowering parents and educating them, because they're the primary caregiver to their child, and that's who we're looking for, or who we're supporting the most, children, because children matter more than anything. But so thank you so much for your time. I will be saving this on my page for anyone that wants to go back and access information. But also, Dr. McIntosh has released 3 books. I think Snored to Death, one of them that he says a good guide, and there's another one that I can't remember the name of it. But they're all available on Amazon.
Snore to Death covers kids and adults. There's one called Don't Ignore the Snore, which is really the scientific one, where I go through a whole list of associated medical conditions and just share a bit of research and science on those. And then the most recent one, Sleep Disordered Breathing, a parent's guide that's totally dedicated to kids, and it covers everything we talked about, like iron, allergies, tonsils, just the works. So that parents have got something behind them, so that if they are hitting these brick walls and feel that, you know, they want or need to make progress from what they've learned, well, as you've said, don't let the system beat you.
Yeah,
just take
absolutely, absolutely.
Just take the initiative and take control yourself.
Yeah, and just to wrap up, I normally do this thing with my friends after our workout. We have a word of the day. So because I'm all about words and vocabulary, what word of the day would you add to your day tomorrow to make your day better?
Oh, look, I have 2 words that I use every day at work, and that's unicorns and dinosaurs. You know, every kid
Why is that?
that's in age appropriate. That's all we're talking about.
Yeah.
So let's just go. I'll steal 2 words, and they're not new words. They're just going to continue the flow. Unicorns and dinosaurs.
Unicorn and dinosaurs. Well, that's so lovely to hear, because I'm sure that adds so much positivity and joy to the children that you see as well.
These kids, you know, the mum will go, look, he's really anxious. Like, it happens like 3 times to go. You know, oh, look, he's a bit anxious about being here. You know, it's like, oh, that's okay. So, yeah, Fred, do you like dinosaurs? And he's just,
bang.
Oh, cool. We're going to look for dinosaurs soon. Is that all right? And he's like, and then all of a sudden, they're like, and I have dinosaurs at home, and it's just like, kids just,
it's so beautiful.
You just got to talk kid. You just got to talk kid.
Just got to talk kid. Exactly right. Well, I hope your day is a childlike tomorrow and you have a gorgeous day filled with dinosaurs and unicorns. But again, thank you for your time. I really appreciate it. And I'm sure many families have significantly benefited from our chat tonight.
Even if it helps one kid, that's all worth it,
That's
right?
all that matters.
Yep.
That's all that matters. Thank you again. Have a lovely evening, everyone. And take care, guys. Remember, don't ignore the snore.
Thanks all.
Have a good night. Take care. Bye-bye.
Bye.
How do I end this? Here we go.
You're on the same page as me. I have no idea.
See you later.